what is best for me and my family is a central driving question in healthcare. And arguably the reason some of us show up to work every day in trying to conduct research or conduct patient care. We're trying to find and give patients or co-create with patients what is best for them, particularly in relation to advancing their goals for health and healthcare. This is a special talk for me because I'm going to take a step back and look at 10 years of work. And that, of course, that's not my work. It's work of a team. We could not be as productive as we have been with solo work. This is a work that also includes patients, as you will see. On the bottom is my Twitter handle in case you are involved in that sort of activity and you want to share what you're hearing and learning today with others not as privileged as you being here. And also my email is there with the intent that if there are any questions or thoughts that were to stay in your minds after the talk and you just didn't get a chance to ask directly or participate directly and you want to do it later, I welcome your notes, I welcome your emails, and I try to respond very quickly. The work that I'm going to describe has taken place in the Knowledge and Evaluation Research Unit, or KER unit, and I'll be discussing that a bit later. One of the hallmarks of the work that we have taken is that we have not had any financial relationships with for-profit interests in doing the work that will be presented today, or any of the work that we conduct at the KER unit. The main points I'm going to try to make are here, so if in case you want to leave, you can leave now, because this will be the main points. The first one is, I'll invite you to look at our work. When you look at our work, I will hope that the way we have conducted ourselves and the way we have conducted our work, the way we have chose to do this work, it should tell you what matters to us. It should reflect our values. If we've done this properly, it should reflect what is important. And I would like you to look, as I present, look at the way we've gone about doing it and try to glean from that what you think is important to us as a team. I want to make a point that is often not made. Our work is political. We are interested in change. We want to change the world. We want to change the way people think. We want to change the way people act. We are not interested in just creating another paper and finding out another piece of information. We want to create a better world for us, for my kids, for your families, for our patients. Our work is social. We work in teams. We work with patients. We work in healthcare. We work with you. It's social. It's not work that is done in a computer, in a room with the door closed. Don't talk to me. It's social. And it is deeply contextual. The work that we have done could not have occurred any other place in the world. It could not have occurred in any other time in the history of healthcare. It is placed in this context that is very important when you do this kind of work to be mindful of the kind of world that you're living in so that your work can be effective. And our vision has changed over the decade that I will be describing today, but we arrived today at the idea that healthcare fundamentally has to be careful. And by careful means, is this the right patient? Is this the right treatment for the right patient? It's about quality. It's about safety. It's about being careful, right? We don't need more jargon than that. It's just be careful. And it has to be kind. It has to see each patient for who they are in all the things that make them special, and be respectful of those limitations and the suffering and the challenges that they have and they live through. So we need to make sure that healthcare is careful and that it's kind. And you say, well, you just showed that slide. Why are you showing it twice? I told you that our work is political, and that I told you that we have to be deliberate. And I'm showing this again because one of the first acts of being deliberate and being political was when we started our work 10 years ago, we basically said, we're just not going to go for funding. from any kind of corporation in relation to our work. Why, are you anti-business? Are you some sort of closet communist? What is the nature of your problem and difficulty? No, it is that our work was going to be about helping patients make decisions. And we didn't want, at any point in time, for clinicians or patients to ask the question, is he or she recommending or placing the options in this particular way because they got funding from the maker of that particular device? Is that we didn't want those financial relationships to represent an alternative explanation for the decisions that we were making in terms of presenting information or showing different things. Not necessarily because we thought we will be corrupted by that, which I actually believe that it will be the case, but not because we will think we'll be corrupted by that, but because we will think that it will present an alternative explanation for the way we conducted ourselves. And we wanted to avoid you having an alternative explanation. If we did something dumb, we wanted you to be convinced that it was because we are dumb, not because we were paid to be dumb. What is best for me and my family? Again, a driving question in healthcare, but it's one that we cannot answer with confidence for at least 3 reasons. The first reason has to do with the nature of the evidence, and I'm going to spend the first part of the talk going through why that is, and then we'll come back to other reasons why there's uncertainty. I was a resident, 1998, 97, and I met this Irish dude who is an endocrinologist. I'm an endocrinologist now, diabetes and physician, and this was a consultant in the division of endocrinology, and he was trying to do some work on fish oil in diabetes. I thought it was the most boring topic ever, but he was doing something interesting with it. He was actually doing a meta-analysis. He was summarizing all the data on the value of fish oil in diabetes. And at the time, another Irish guy and another distinguished member of my division published this paper in the Mayo Clinic Proceedings. And in this paper, they basically reviewed the role of fish oil in diabetes and basically pointed out, mentioning a couple of studies, and that said at the bottom that these agents should be used with cautiously in subjects with diabetes mellitus. Because these fish oils can make the sugar go up. And then we did the study of looking at all the studies that were available at the time, formally, and we found that, no, fish oil did not affect the sugars in people with diabetes. So how come 2 top experts from the world-famous Mayo Clinic, publishing in the Mayo Clinic Proceedings, were able to say, oh, be careful, this is a problem. And a resident, internal medicine resident, can go in and look at the evidence and say, there's no problem. And this was my wake-up call to know that you can be an expert at the top place in the world, but if you do not practice evidence-based medicine, if you don't have the skills to work through each of the issues you're going to make statements about, you are going to not be able to answer correctly to the question, what's best for you and your family? You're going to get the evidence wrong. This has implications for how we have done things at Mayo. Right now, we have a big component of the enterprise, the Ask Mayo Expert Enterprise, where anybody in the Mayo Clinic Care Network or even here can look up and see what Mayo Clinic experts think about these issues. And there is no requirement in there that those experts would have these skills and be able to do these sorts of things. That creates some challenges for us as we look at that source of information. But I didn't know that at the time, and this opened my eyes to the fact that even here there was an opportunity to improve what we know by following certain rules of evidence. But then I figured that the problem was bigger than just our top experts in one of the top medical institutions in the world. We have a problem of the evidence in general. And we did some work looking at what were the characteristics or the limitations in the top papers published in diabetes. And we found that many of them, these are characteristics that protect studies from bias, many of them did not have adequate quality in terms of what they had to offer. And so we said, okay, which are the papers that have the highest quality? And what we found is that the papers with the highest quality, the ones that you can believe the most, are actually produced by funded by for-profit corporations. And this introduced a very interesting challenge, because the people that have the most interest in a particular outcome of a study, say trying my product versus the competitor, I have an interest in my product coming on top, they were actually conducting the best studies, the ones that we should trust the most. And one of the things that we found is that the studies that were funded by for-profit interests were more likely to find in favor of the product of the sponsor. So how come you have the best, most trustworthy evidence on one hand, and these studies that consistently, again and again and again, were more likely to benefit the product of the sponsor? Weren't those features supposed to protect the evidence from bias? And here it seems to be bias, unless these drug companies are just really lucky, that every time they do a study, they get something in favor of their product. There are a bunch of reasons why that happens. They might do 5 studies, find 3 that are positive, 2 that are not so much, hide these 2 and publish these 3. And there's been a lot of work over the last decade to try to prevent that from happening, registering trials, and all sorts of efforts to have complete reporting. But we uncovered something else. We uncovered that there is a lot of spin in the literature. And one example of that has to do with how you ask the question. And you can ask the question in ways that if you're not paying attention, you might get a sense of the truth that is not the one that we're looking for. So here's a high-quality randomized control trial published in the New England Journal of Medicine in 2001, taking a bunch of patients with diabetes and high blood pressure, treating them with 2 different antihypertensive drugs. And this is the result. Treatment with one of them, with irbesartan, was associated with a risk of the primary composite endpoint that was 23% lower than that in the amlodipine group. And it's a p-value with a bunch of zeros in front. That must be cool, right? Now, if you look at, there's a little asterisk here, right? It says the primary endpoint. What was this composite primary endpoint? It's double the amount of creatinine in the blood. So you check the blood and you measure it. The creatinine went from this number to this number, doubling that. You have end-stage renal disease, so you need dialysis, or you die. Okay, so this is an outcome that includes a change in a laboratory test result and death. Right? I put forward that these are 2 different experiences. But we know from this study that the risk of that is reduced by 23% if you take one drug versus the other. Okay, so now, if you're trying to help Mrs. Jones find out what's best for her and her family in terms of choosing an antihypertensive, right, you'll have to be able to explain to Mrs. Jones that this antihypertensive is better than this because it reduces this stuff by 23%. And so Mrs. Jones is going to say, so, doctor, if I take that medicine, I'm going to have 23% lower chance of dying, right? Well, when you look at the data in detail, you can see that the laboratory test, yes, that first drug reduces that risk of worsening the laboratory test by 1/3. The dialysis thing, well, that gets a little bit close to what we tell Mrs. Jones, but it's not significant, so the result is too imprecise. And then check out that mortality result. That mortality result is on the other side. Actually, the best guess, although it's very imprecise, there are very few people that died in this study, thankfully, is very imprecise, but the point estimate is on the other side. There's a 3% increase in the risk of dying. So this introduces a challenge in explaining to Mrs. Jones what's going on in this study and deciding with her what's best for her, isn't it? But it is the top journal, the best papers and stuff. It's the way the answer was framed, the way the question was asked and the answer was framed, the outcome was selected, that introduces complexity. There is no physician no expert that's going to sit down with Mrs. Jones and explain the breakdown of these composite endpoints. It's just too So what you're going to do is you're going to choose A over B because it reduces all these bad things by 23%. Well, it doesn't reduce all these bad things by 23%. The one thing that you have the most confidence in is that it changes a laboratory test result. This is my favorite example. It's now a very old example, but it's wonderful. So this is there was a time where we didn't know if sugar control was good for people with type 2 diabetes. So this study was organized in 1977 to answer that question. 5-year study. By 1982, they still got nothing. They couldn't show that sugar control was good. So they got more funding, went for 5 more years. And then 5 more years, and until 1998. So, about when the principal investigator presented the results, it was at a basketball stadium in Barcelona. I happened to have the chance to be there. His first slide was a picture of him when he started the trial, and a picture of him after. This guy was, like Mick Jagger. It was very sad. So he actually died on tour. So he disseminated the results of this trial and died alone in a hotel room in New York. Worst case scenario for a researcher, I think. The ultimate bad outcome. When they were not finding impact, they kept adding components. So in other words, we're interested in stuff that happens to people with diabetes that matters, right? So death. We don't want people to die, so it's important. Heart attacks, chest pain, heart failure, strokes, really important. Renal failure, amputation, bleeding in the eye. Oh, when the surgeon puts laser in your eye, blindness, and then cataract extraction. Again, I put forward that dying and getting your cataracts removed are completely different experiences, right? But again, we were told that if you control sugar very tightly for 10 years, very tightly, you get any of these in 35% of people. And if you don't do it very tightly, you get any of these in 38% of people. Okay, that's a difference of 10 years of tight sugar control. So a difference of 3%. Significant. When this was presented, the audience went nuts. Half the audience went out. There were no cell phones at the time, so they went out, pay phones, called in, buy stock of the different medicines. It was actually really interesting. But next to me was this Irish endocrinologist that introduced me to that fish oil study, and he elbowed me and said, "That's exactly what we were hoping to see. That's exactly what we were hoping to see." That is exactly what we were hoping to see. In other words, we have invested in our patients so much about this sugar control that if this study had been negative, we would not have been able to save face. This is exactly what we were hoping to see. Now, that difference of 3.2%, do you think it was on death? Now, by this time, you kind of have, where I'm going. Do you think it was on death or heart attacks or amputations or dialysis? It was... actually, the line has moved. It was actually over here. It's on the number of laser procedures in the eye. It was not blindness, laser procedure in the eye. I don't know why that moved down. But 2.7 of the 3.2 were on that retinal photocoagulation endpoint, which happened to have been the last endpoint added to this list in their quest to find a p-value less than 0.05. Mm-hmm. These composite endpoints, this combination of endpoints became a problem. It's not enough. Our work is political. It's not enough to highlight that people can be misled by these composite endpoints. It's important to tell them how they should prevent being misled, how they should sort of de-spin these issues. So we came up with 3 questions you can ask. Is there a gradient of patient importance in the components? Death, cataract extraction. Is there a gradient of treatment effects? No effect or 3% increase in mortality, 33% decrease in doubling of creatinine. There's a gradient in treatment effects. And is there a gradient of events? A handful of deaths versus multiple laser procedures in the eye. And then we looked at the cardiologists, which by all means, they're the greatest offenders of all this stuff. And so this is, anytime I have an opportunity to go after the cardiologists, I take it. So here's one. So there are 242 randomized trials in cardiology. 112 used composite endpoints like this. And 86% of them failed the first 2 criteria, which basically means that our experts looking at this evidence should not be able to interpret the primary result of all these trials by looking at the composite endpoint, because they will have very large gradients of patient importance or treatment effects. This unfortunately gets ignored consistently. Another aspect that we went about in this journey in terms of the evidence, in terms of clarifying what's best for you and your family, is that many times patients get confused by the messages that they get. So I think all of us have lived through this. This rosiglitazone is also known as Avandia. And there was a period of time where Avandia was known to, or considered to increase the risk of heart attack by 40%. And there's a bunch of people who said that was a meta-analysis, boo-hoo, meta-analysis, who cares about meta-analysis? I don't know what they mean, I don't know what they do in the meta-analysis, therefore I don't trust it, I don't care about reading about it, I want to stay ignorant and distrust it, and I don't like meta-analysis. And other people might want to say, no, Avandia is unsafe, look at the evidence. And so there's a big debate as to whether Avandia could be trusted or not, and people were prescribing or not prescribing. For instance, in the division of endocrinology at Mayo Clinic, this drug was not prescribed. In fact, this class of drugs is very underprescribed here, as it is in the state of Minnesota, turns out. So our colleagues in our group went and looked and see what explains this disagreement. Why do we have this debate? Is it a debate on the evidence? And what we found was a bit challenging to us, in that if you look at the people that were in favor of the safety of rosiglitazone, there was a 90% chance that they'll have a financial relationship, and that financial relationship will be with the makers of these drugs. So one of the things, so the odds or the risk that they will be in favor of the safety of the drug if they had a financial relationship was 6 to 1. So one of the challenges here is to say, well, so these experts are bought. Is that what's going on? And I go back to our disclaimer. It's not that they're bought. It's that we now have an alternative explanation for their opinion. It could be that they truly believe this drug is safe. It could be that they have to believe that way because some of their income depends on this. Or it could be that because they believe that on the safety of this drug, the company has provided them with income to further their research, right? So I can't claim the cause and effect, but what I can claim is that for the end user, for the clinician in the front line and the patient, these experts are now debating the benefits and safety of the drugs. Could be doing it on the basis of their expertise, but now I have an alternative explanation. And that alternative explanation is these financial relations. And as a result, I cannot necessarily trust their point of view because of it. That undermining of the trust of the experts is one of the contributions of this paper. It's not the cynicism that should follow, but rather the fact that experts cannot be trusted just on the basis of who they are. The evidence, as we look at it, had other limitations. For instance, it told us the importance of diabetes treatment on outcomes that didn't matter to patients, just laboratory test results, not quality of life, not things that you will perceive and experience, like an amputation, like blindness, like a renal failure. And we did a study looking forward to see in the trials that are being planned for diabetes for the next 10 years, how often would we see that they will measure outcomes that are important to patients? And the answer was only 1 in 5. So even if you want to be a high-quality expert that reads the medical literature with some degree of critical skepticism, but also with optimism and enthusiasm, trying to help your patients, the evidence that comes back to you is evidence that does not fully inform or directly inform the outcomes that patients are interested in knowing about. What is best for you means, hopefully, that it is best in ways that you value. So how are you going to feel? Are you going to be able to live longer and feel better? And we now know that the evidence is unlikely to answer those questions regularly. And this has interesting implications. Our group then went to Minnesota and asked 4,000 patients with diabetes, so what outcomes matter to you? Right? We're talking about patient-important outcomes. Has anybody asked patients what matters to them? So we did. And this is just absolutely phenomenal. So the one that they ranked first, the number one, is death, right? So patients are, I don't want to die, so death is very important. The number 2 was a laboratory test result, was the hemoglobin A1C, the measure of diabetes control. So how is it that patients thought that getting an A1C to improve is better than avoiding a stroke or dialysis or an amputation or blindness? How did we do that? And you can trace that back to the campaign that was that focused on lowering A1C to less than 7 by 2007, a campaign that was heavily underwritten by the sponsors of the American Diabetes Association, and for that Mayo and others have participated quite actively, such that it became really important to patients because we told them it was important that their A1C should be lowered. And we went so far as to make it more important than getting a stroke. And so one of the challenges that we have is that if we measure something that is not important, and then we tell people they're important, we can convince people that it's important even though it is not important. And so the political work is now to refocus and recast and re-challenge everyone to say, no, 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 no. What was important? Where did we miss the boat? Let's refocus. Let's re-engage. And so then we used to use strong words like this, right? So with one crazy colleague from the UK and a very bright colleague from Connecticut, we wrote this paper on the idolatry of the surrogate marker. Surrogate is a replacement. So instead of stroke and death and heart attacks and kidney problems, we're using hemoglobin A1C. And that's the most important one, and that's the one we are going to work on. And we're pointing out that it creates an enormous challenge to the care of these patients if we focus on that. A couple more things about the evidence, and then we're moving on. This is work that one of the endocrine fellows led with other folks in our team. The way we ask the questions, again, if you look at the way we work, but also look at the way others work. This is the body of evidence about medications to control pain in patients that have nerve damage due to diabetes. I would say that the shape of this evidence is like a star, right? Different drugs are tested against placebo, okay? But you have multiple drugs available. If I'm coming in with a new drug and I want to test it with another drug, I want to test it head-to-head. I want to say A versus B. Is A better? What is best for you and your family requires me to tell patients, here are how the options compare. But look at the shape of this evidence. The shape of this evidence is a star. If I want to compare these different drugs, I'll have to compare them through placebo. I have to compare them indirectly. That reduces my confidence in the comparison. So the way the questions are being asked reduces our ability to answer the question of the patient, which is, doctor, what is best for me? Notice how few comparisons are head-to-head across different agents. And so as a result, the clinician at the front line only is able to provide best guesses. So that's in a nutshell 10 years of work on understanding how the evidence falls short in helping us answer the question, what is best for me and my family, and how going deep and trying to uncover that might help people use the evidence better in answering that question. As you can imagine, it's very, very popular kind of work. Gets you invited to parties and stuff. The next line of work is, the next line of uncertainty, why is it that we do not know what's best for you, is what's best for you depends on what you value. Right? What's best for you depends on what you value. And so understanding how to work with patient values and preferences was the next challenge. Check this out. We talked earlier about Avandia or rosiglitazone and how there was some controversy about its benefit. And there was reviews done by other groups showing that there's really no specific advantage of the different diabetes drugs, that they just differ in terms of their side effects and costs. This is work that our group did. It was published in the New England Journal of Medicine, showing the distribution of Avandia or rosiglitazone use in the United States. And you can see that there are different states that use, there are states that use a lot of it or used to use a lot of it, and states that use very little of it. Now, what are the potential explanations? It might be that in a particular state there are formulary policies that promote the particular use of the drug. It may be that there is a key opinion leader that operates in that particular state that believes in the particular drug and convinces his or her colleagues to take the drug or use the drug in their patients. It might be that there's a very special drug representative, drug company representative that is able to, good salesmanship, get the drug to be used massively. It could be that people that live in these contiguous states are, in fact, quite different from each other. living over here, no, I will never take that drug. Oh, I'll take it. No, I won't take it. I'll take it. No, I'll take it. Just by going to the other side of the border. That's unlikely, right? So this is unlikely to reflect patient preferences. This is much more likely to reflect something other than. So we basically started a journey in which we started to think, how might we bring what's important to patients into the conversation, into the consultation? So we developed these shared decision-making tools, we tested them, and now they're being spread. This one is for the diabetes medications, and the way it works is extremely cool. You basically are a patient with diabetes, you need to choose your next medicine, and so the doctor shows you, or the nurse shows you these cards, and it says, which aspect of your next diabetes medicine would you like to discuss next? That is very different from the situation that is recommended by the professional organizations, or at least it was until recently, in which they have these complex algorithms in which, depending on your insulin resistance, size of your belly, your liver, I don't know what other things, the doctor will tell you what the next drug is best for you. Here we are able to understand what's best for you depends on what things you value and what are the reasons, not only what things you value, but what are the reasons you have to value one over the other. What makes that choice eventually a reasonable choice for you among the medically reasonable options that I'm presenting you? So a patient might decide to look at the diabetes medicines on the basis of their effect on weight, and might discover that there are a couple that can help them lose weight. Now, I tell you, in the randomized trial, when we did this, the issue of weight was never brought up in the control group. So the number one issue for the people that were giving an option to speak up about what matters to them was never discussed in the control group, never. And we're talking about, again, the world-famous Mayo Clinic. And so if you look at the two options that can help you lose weight, the patient might say, yeah, I'm interested in losing weight. I didn't know I could do that with diabetes medicines. What aspect of those medicines would you like to learn about next? And the patient might be interested in saying, how do you take them, doc? And so you say, well, this one is an injectable medicine. You can inject it once a day, once a week, or twice a day. And some patients might say, oh, needles, no, I don't want needles. Other people might say, gosh, I'm going to lose weight. I'm going to inject my eyeballs to lose weight. That's not a problem, right? Then on the bottom, the people that are not interested in the injections might see that there is an opportunity to lose weight, and there's a once-a-day tablet. They might be interested in that. Okay, so the once-a-day tablet. Okay, what aspect of that medicine would you like to learn next? Oh, how much will it cost me out of pocket? And they might discover at that point that that's an $8 a day. Say that they were on metformin, which there used to be a 10-cent a day medicine. Now it's an $8 a day. Wow, is that 80 times better, doc? Or is it the company got 80 times greedier? And it's the latter, of course. But the issue is now you begin to bring some transparency to these things. You do not want the patient to go to the pharmacy, get the sticker shock at the pharmacy, and only you as a clinician learn about this not being the right choice 3 to 6 months later, and you've wasted all the time for the patient. But for some patients, that's not important. That's not what valuable, and they're willing to spend the money to actually get the treatment they want to get, and that's what they're going to do. What is reasonable for each person depends on each person and their circumstance, their biography, their current situation, things that we cannot access, no matter what our expertise, without the patient. So this work was fundamentally to put the patient at the center. We also did this with statin, which was the first one we developed, and begin to help people, clinicians in particular, notice that this person will benefit the most from the medicine than this person, And that, in other words, that the benefit from cholesterol medicine depends on your risk, where you start. It doesn't depend exclusively on how high your cholesterol is. And then we were able to not just demonstrate that with a clinical trial, but then write the editorials, write the opinion pieces, and try to move the way people think about it so that they will begin to think and act differently, because our work is political. And this was published in JAMA, and what followed after that was is that this tool now is used about 10,000 times a month across the world. And there is some change now in policy towards the use of shared decision-making, which is a technical term for this, in deciding on cholesterol treatment. The third way in which is difficult to know what's best for you and your family is the context of people's lives. It's amazing, right? I look at you here, and I can't see, just by looking at you, what kind of nightmares you live in your daily life. Right? You could have just had a major problem at home. You hate your job. You hate your coworkers. They dress in purple, but you still hate them. I can't tell. You just can't tell. And we're, of course, very quick to judge, but we can't tell. We do not know how difficult people have it in their lives. And what is best for you really depends on the challenges that you face in your context. Here's a big picture. We hear about that people are that societies are getting older, and that there is people are just living into older ages and stuff. And what you see is this is the proportion of people with chronic conditions. And as people get older, almost everyone has a chronic condition. But what people tend not to see is that people in middle age are beginning to also behave as if they were older in terms of their diseases they're accumulating. And so if you look at the middle of this graph, in the middle age group, the average person in middle age is no longer a healthy person. The average middle-aged person has one chronic condition. So think about places like Mayo Clinic as we prepare to face the next wave of patients. We may be perhaps over-preparing for cancer and heart disease and all these things that affect the very elderly. But how are we going to deal with the fact that even our own employees and dependents, which probably will be at the beginning there, how are we going to deal with the fact that they're not going to just be sore throats and vaccinations, that we're going to have to deal with hypertension and back pain and depression and diabetes, and we're going to have to be able to provide them care that fits their context, which is not, I'm retired, I have all the time in the world to sit in our waiting areas until the doctor and the nurse are ready to see me because I'm retired, I just don't do anything else with my life. But rather, I need to go back to my unit, are you going to see me on time because, I just have to take care of my own work. Right? It's not easy for me to take time off work. Can you see me at 7 o'clock at night when I'm off my job so that I can get the care that I need? We're not even having those discussions. But these are different kinds of patients. Part of the reason we're having patients having more and more chronic conditions is because we're inventing them for them. We are making them patients. So again, when you see these sorts of things, you have several choices. One is to go, can we take advantage of this thing? Well, we can come up with a pre-diabetes service and, bring some more patients to Mayo Clinic. Or we can say, are we interested in actually giving people healthy years to their life, or are we interested in making everyone a patient? And so again, with the crazy English guy, we wrote another thing saying, why do we have an epidemic of prediabetes where we have, 500 million Chinese people now that, if they were to come in, they will get this diagnosis of prediabetes. Who benefits from that? Somebody tweeted the other day for me what they calculated our proportion of people in India will have prediabetes. It's like, like 2 or 3 United States will have prediabetes, just in India. And why were the criteria for prediabetes changed? And then why are we treating prediabetes, which is, diabetes is when your sugars are above 126, that's a number. If you're under that, but above normal, you have prediabetes. There are several other criteria you can use. And then what's happening is when you come in with prediabetes, we're supposed to tell you to exercise and diet, and that sort of thing, and lose weight. But you come back in 3 months and you still have prediabetes, so what do you think we're going to do? We're going to say, well, maybe if we just give you one of the diabetes medicines, we can bring your sugars down so you'll be further away from crossing that line, which will make you diabetic. So we don't want you to make you diabetic, so we'll give you some medicine so you won't be diabetic. Doctor, what happens if I become diabetic? Well, I'll recommend that medicine. So you're going to give me a medicine to prevent me from needing that medicine. Mm-hmm. This, which you laugh, is what's happening. And so we wrote this thing saying, well, that's ridiculous. And we've got people respond back saying, no, you are the one that's ridiculous. And we need to prevent diabetes no matter what it takes. And what basically we've done is we made people, we changed the definition of diabetes, which is, by lowering the threshold and treating everyone as if they have diabetes, we've changed the definition. So no one will be left behind as not having disease. And as you can see here, most people with one chronic condition has other chronic conditions. And so part of their context is going to be multiple diseases, multiple treatments, multiple drugs, drug-drug interactions, getting sick with drugs, getting sick with tests that are necessary to manage all these conditions. So comorbidity is one of their contexts that we need to be sensitive to. But the guidelines and policies that we have to control diabetes are not sensitive to comorbidities. They don't pay attention to that. But they also don't pay attention to personal context, to social context. You just got divorced? Yes, but your A1C needs to be less than 7. I don't care you're sad, right? You just got laid off and you're not, your cholesterol needs to be lower. We need to work on your cholesterol. If you're not healthy, you're not going to find another job. What? And so, and their guidelines are blind to patient preferences. Their policies are blind to patient preferences. Now, I don't want to be unreasonable. Our guidelines cannot pay attention or consider all the diverse patient preferences that there could be, all the potential contexts that there could be, which basically means that our guidelines should not be turned into things you must do in every patient, right? They must be guidance, and then the professional and the patient working together on the front line, they need to work towards finding what's reasonable for me right now, what's best for me and my family right now. So to the extent that we take these guidelines and make them into quality measures, that if you don't follow them, you're a poor quality clinician, we will then impose this on everyone. And the result is enormous amount of work. Work that takes maybe 2 hours a day or more, but there's very little research on this, and work that comes up in the consultations, but we clinicians have no way of addressing. That's that data in the bottom, our Mayo Clinic visits, 24-minute in duration, in which patients brought up issues of work. I'm overwhelmed by my care. And the clinician in 70% of cases could not address that or could not remediate that. We have very little understanding of what is the work of being a patient, so our group is working towards understanding. If we don't understand it, we're not going to be able to at least have sympathy for it, if not try to improve it. But the work of being a patient might be the work of making sense. This is when you go and Google your disease, when you read your package insert to understand the side effects. It means supporting the work of organizing, pill boxes and working together, coming to visits, doing the work, and then reflecting, is it all worth it? This is the work of being a patient, yet we just don't ask for it in the consultation, and we don't support it actively necessarily. Some things we do, but we don't know what we're doing. So we have a fantastic section of patient education downstairs. That section, for instance, needs to help patients make sense of their disease and treatment. I think they do a good job with that, but we just don't refer enough patients down there to do that. We try to do it ourselves in our job, but who knows if the quality of that's any good, whether it helps people do the work they need to do. More on that. But we need to also give them something to reflect. Are you better off because of the work you're doing as a patient? How do you know? And how do we do that with conditions that are asymptomatic? Very hard. And then we need to recognize that to do all that work, patients have to mobilize resources. They have to have resilience. They have to be able to bounce back. Their literacy. They have to have this concept of bandwidth. You will recognize this. You're very smart, but say you're very worried. If I give you a math test, your capacity to answer that questions correctly will be lower than what your usual IQ, your smartness will predict. You become dumb with worry. And that can be done by a financial stress, by too much email, by too many meetings, so in other words, running out of time. If you need to go to hospital, you have a dog at home, and you need to have someone to take care of your dog, and you realize at that point you have no one else. You have no one in the world that you will trust your dog to. Now answer these 5 questions about finances. You're not going to be able to. That's not because you've lost brain power, but your bandwidth has been reduced. This is the equivalent of when you have too much software going at the same time on your computer and you get the little wheel going. Mental health problems obviously reduce your capacity. Physical function and health problems. If you have a bad knee, a bad hip, it's going to take you longer to get someplace, so you only can do a few places. So you will only be able to do a few things. Financial health, obviously, big problem. Social skills and social network. If you're alone, you're lonely, it's hard to get the help that you need to do the work that you have to do. But if you also have poor social skills, even if you're lonely, you won't be able to get anyone to help you. Right? And you know these people. Right? You work with them. Let me show you the, why was I rewinding this? I was going to show you,
Are you stressed?
oh yeah, this thing. So check this out. So he doesn't look sick. Right? He just looks lazy, maybe. I don't know, right? But he needs her for her to, on Sunday at 3:30, call him downstairs and say, dude, it's time to set up your pillbox for the week. If she doesn't call him, he won't do it by himself. Right? So, but he has nothing in terms of suffering, missing body parts, blood coming out of a hole, or something. Nothing that will actually get her to be sympathetic to his situation. So he just needs to find a way of keeping her engaged because he needs her to engage him in doing the work of being a patient. If she gets sick, she has a medical alert place. If she gets sick, he's toast. He's going to take the pills out of the little containers, and he's not going to be non-compliant, non-adherent, etc. So social skills and social network become really important. So our group developed a model to try to understand this and educate people about how these guidelines and quality targets could increase the burden of treatment and overwhelm patients and families, making it hard for patients and families to understand or to convey that what appears at first glance to be the best for me and my family, I can't implement. I can make it work because life gets in the way, job, marital situations, all financial issues, they get in the way, they consume my capacity, and I can't implement this work, or because I have limitations in my resources. This is where that kindness part comes, because we need to begin to see the patient in all their complexity, in all their context. And it manifests in terms like this. Oh, here's a non-compliant patient. What a terrible term. Check this out. This is an experiment that is only happening in your brain. Say Saturday you're having a birthday party. It's your birthday party. You're going to invite some people over. Would you invite a non-compliant person? You probably wouldn't, right? I mean, who wants a non-compliant person in your party, right? Why? Right? But the reason is non-compliance comes with this, badness. You just don't want to be around somebody that's non-compliant. So we need to change our language. We need to change the way we think, because non-compliance is a dead-end situation for that patient and for us trying to help her. Finding out what's best for her is very hard once we have that picture of this person. Right? And so part of our work is political, needs to change the way people think, the way people act, is to change the words people use to describe situations. Those words change the way people think. And so, for instance, if we were to think of her as, gosh, we overwhelmed her. She has this limited, precious capacity, and we just disrespected it and asked her to do this, until, boom, she can no longer do it. And now we say it's her fault. She's non-compliant. Right? But we, to some extent, misdiagnosed her capacity, misunderstood what she was able to do, disrespected her. We were not kind. So it's a kinder healthcare, one that begins to interpret the situation in a way that gives us an out, gives her an out, gives her hope. Our team here in the front has actually done some work to try to bring those conversations about the complex life into the consultation. So, is your family a source of satisfaction? Is it a source of burden? Is it both? If it's a source of satisfaction, could they help us out here in achieving your goals as a patient? If it's a source of burden, gosh, to what extent is it a burden? What do they leave as a capacity for us to do work to improve your health? And then you can see on the other side, this is when they write our treatments. Oh, doctor, you're asking me to check my sugars 4 times a day. All right, is that a source of help? Or is that a burden? If the patient interprets it completely as a burden, do you think they'll keep doing it? They'll be like many of my patients who have their logbooks written with the exact same pen, with the exact same handwriting, day after day after day after day. It's just not likely to be true. I mean, I want my logbooks to be bloody and stuff, and this was just too clean. But clearly those things are burden to them, and they don't see it as a help. If they don't see it as a help, maybe it's not a help. But it begins to bring all sorts of transparency about what that context is, both in terms of what they have to live with their life and also healthcare. And there are efforts now at Mayo Clinic to try to bridge that with capacity building organizations in the community, that we can refer patients to actually get that extra boost from community resources. There are tens of organizations in the community that are dying to help people. But if you ask them what is your biggest challenge, is they can't reach their clients. And we have a ton of patients who need all the help they can get. And they just don't know how to get that help. So there's some interesting work going on, for instance, in the Center for Innovation, trying to connect the two. The idea, of course, is that more social support can rebalance these people. So if we think about, for instance, respecting capacity limitations, our work is really focused on how to reduce the waste in accessing and using care. You can't see this picture very well, but these are people sitting here. They're supposed to be standing in line, but what they've left is they left their shoes to stand in line for them. And they're clearly demonstrating that this place, to the extent that it has waiting areas and it has queues, it doesn't respect one of the most precious resources, which is their time. Sorry. And so that is what we've been calling minimally disruptive medicine, is healthcare that respects patients' limited capacity while pursuing their goals. To do this work, we've partnered with patients. This is our patient advisory group. We're giving these patients voice, and there's a group here in the room that's working in the community now, trying to get patients to have better conversations with their clinicians. Creating workshops. The last workshop is later tonight in the public library. I invite you to come. It's from 6 to 8 o'clock. Anybody can come. And the discussion is, how might we have these difficult, awkward, challenging conversations that will help my doctor and I come up with the recommendations, with the treatments that will really be the best for me and my family. So we'll not only do the work from this side of healthcare, but also try to empower patients to try to get the healthcare that they need and want. We gathered a group of women one morning and said, here's the evidence for mammography under the age of 50. You've heard about the controversy. Let's have a discussion. What is best for you and your family? And these women were able to discuss in ways that were very different from the way we have the discussions both at the policy level at Mayo Clinic and also at the level of the public. A second one of those workshops for mammography screening is going to happen in Connecticut in the next month. We're working with a medical journal, the British Medical Journal. We started having patients review scientific papers, write editorials about scientific papers, and begin to have a voice that speaks directly to academic medicine. And there's this idea of working towards a patient revolution. It's a little subtle. There's a P and an R there. It's patient revolution. But you can see like a dude, with like the hands out. But the idea of working towards a patient revolution in a situation of bringing healthcare to be about what is best for you and your family. So that's been the decade. We've spent 10 years working on helping us all, trying to do a better job asking this question, and answering this question with our patients. It's been a wonderful journey. And one that I think, if you've picked up the way we've gone about it, is highlighting that what matters to us as a group is the best interest of the patient, defined only with the patient, not for the patient. That our work is, in fact, political. We seek transformation. It's contextual. It's social. It needs you. It needs us working together for this. And that we really think that healthcare should be careful and kind. And we find that our job has been, up to this point, to advance that vision through research. I hope that I've convinced you that all of us have an opportunity to advance that vision from each of our vantage points. And it may be perhaps one of the best ways in which we can manifest our true commitment to our professionalism and values. Thank you very much for your attention.
For questions. Did anybody have a question they'd like to ask? Okay. Well, I just want to thank everybody for attending. You will be receiving an evaluation in your Outlook. Please respond. We value your input to make our program better. And please join us for another seminar series. Thank you.
Your conference is scheduled to end in 2 minutes.
Thanks, Edna. Appreciate it. Thank you so much.
Sorry, I've been Have you been? Did you find the baseball? Yeah.
Great talk. Appreciate it.
Good. How are you?
Your conference is now over. Goodbye.